Hi, this is Dr. Michael Lutz, and I am the president founder of the Michigan Men's Health Foundation. We are glad that you're joining us for our first Men's Health Survivorship series. We are now talking about all topics related to men, and tonight's topic is about erectile dysfunction and Peyronie's disease, and all the other acronyms that have come along with it over the years. The Michigan Men's Health Foundation is growing in its activities, and that is why the rebranding. We are going to be doing activities and outreach services across the state of Michigan with some of our new partners, and we want to thank our new partners as we move into Grand Rapids and other cities around the state of Michigan. We have plenty of activities planned for this year, and we are obviously very excited about our activities. We have our events coming up in June, and we hope that you'll join us during June. International Men's Health Week kicks off on June 9th, which is a Monday, which is Blue Monday. And Blue Monday Men's Health is where all of us share in men's health messaging, wear blue, support the men in our lives, and share stories for the support of men in our community. As well, on the same day, we have our Cogs and Kegs event, which is on June the 9th over at Lincoln Yard in Birmingham, Michigan, where approximately 200 to 300 cyclists will join us for a really great evening of a 10-mile as well as a 30-mile ride. You can still sign up for that event. It is a police escorted ride. It's a fabulous ride, and anybody who's a cyclist will tell you that it's probably their favorite event of the year. And the reason it's called Cogs and Kegs is because after the Cogs, we have the Kegs, and there'll be some beers to drink and some food to eat at Lincoln Yard on Monday, June 9th, kicking off International Men's Health Week. During the week on June the 12th, we have our event called Mulligans for Men, which is a golf gala over at Top Golf. We would love to have you join us. And as well, we round out the end of the week with one of our favorite events, which is our Run for the Ribbon at the Detroit Zoo, celebrating prostate cancer survivorship for men and their families. And we really would love to have as many people join us for this event. Fox 2 will be covering it live, sharing the stories of men and the survivors and their families. And it's just a really great event to be at on Sunday at Father's Day. And as well, if you run in the event, your bib that gets you into the run gets you into the zoo for free. And what could be better than visiting the zoo on Father's Day? We don't have our date yet for our men's health event, which is in the fall. And if you stay tuned or go to our website at michiganmenshealthfoundation.org, you'll be able to discover when the date is and sign up for that event in the fall and join us. Tonight, we're going to be talking about erectile dysfunction and particularly Peyronie's disease. Peyronie's disease historically has been around going back to 1687, and in 1743 was discovered by Dr. de la Peyronie, and he described it as rosary beads of scar tissue on the penis, causing an upward curvature. The cause of the disease has gone through a lot of history. Back in the 7th century, it's thought to be caused by incest. In 1267, they called it black warts and thought to be contagious. And in the 18th and 19th centuries, was thought to be associated with gonorrhea and syphilis. We got a little bit smarter later on and realized that the disease was associated with what's called Dupuytren's contractures, which is scar tissue that can form in the palm of your hand, and that is transmitted as autosomal dominant, which means we believe that there's some genetic or inherited component to this. Later on in the 19th and 20th centuries, we believe that gout and diabetes may be associated with the development of Peyronie's disease. And then later on, we believe that sexual trauma may be one of the most causative factors for the development of Peyronie's disease. Now, more recently, it hasn't been called Peyronie's disease. And as you may notice, if you watch television or listen to the radio much, acronyms abound. And Peyronie's disease has been rebranded as PD. And I have to give a lot of credit to a gentleman named Justin Matisse from Endo Pharmaceuticals, who was in charge of the marketing campaign and came up with the bent carrot. And you may have seen that advertisement on television. And more recently, a newer campaign called I Got Somebody, which I think is a fabulous campaign. And Dr. Bennett, who I'm going to introduce in 2 seconds, is going to be one of those people I'd like to talk about that because I think some of these campaigns have more meaning than you can actually even believe. So let's talk about the present. Tonight we have Dr. Richard Bennett with us tonight. I've known him since he was finishing medical school, then as a resident, and over at Corewell Health, William Beaumont University Hospital, and then he went on and did his fellowship at Baylor College of Medicine, specializing in men's health and in andrology. And he's also a very, very strong men's health advocate and a supporter, not only of our foundation, but also of supporting men's health in the community within which he lives and works. And so tonight I'd like to welcome Dr. Richard Bennett to join us for this evening. How are you, Richard?
Great, thanks. Thanks for the great introduction, Michael, and the history lesson on Peyronie's disease. It's always great to hear that information. And it's a little sad. We used to think some of the things this was related to when we know now maybe 10% of men suffer from Peyronie's disease of some sort. So to hear it related to incest years ago, that must have been really tough at the time.
Oh, absolutely. In fact, many of the diseases that were kind of like negatively connotated were always associated with incest or sexually transmitted diseases or perverse behavior. And so a lot of men didn't seek help because, in fact, they thought prostate disease, just BPH, plain old prostate disease, was related to aberrant sexual behavior. And so most men would die in retention before they'd ever get attention for their urinary symptoms.
And I think Peyronie's disease was just not a well-known process, and a lot of men would kind of associate it with erectile dysfunction in general. And it's been great to see the direct-to-consumer advertising, like you were talking about, from endopharmaceuticals, kind of just educating our population about what it is and when to go talk to their doctor. So it has been great to see some of that education that's been out there.
And I particularly like that I Got Somebody campaign. They did that because they believe that 1 in 10 men have Peyronie's disease. But more importantly, I Got Somebody is a really important thing for men in men's health advocacy because men in general don't share stories about their health. And if somebody starts talking about it publicly, saying, you really know that if you're with a group of 10 or 15 guys, there's somebody there that's suffering from something that you can relate to. So it might actually help start the conversation, which is what I think is the biggest bonus of that advertisement, not necessarily just Peyronie's disease, but men's health in general.
Yeah, it's been nice actually to see a trend in the last couple of years, and maybe as generations change, things are changing too about men talking about these things. Did a radio interview, right? That's dating myself partially there. Who does radio interviews anymore, I guess? But and they were asking about how do we change this in men, and I said, well, if a man becomes involved with another partner of somebody of the opposite sex, you get married, then women are more used to these things, and the women will get the men to go in and get checked out when there's a problem. But what about young men, single men, maybe men in same-sex relationships where there's not that difference in sexes? And so I think we've seen a shift with younger generations now just being more comfortable talking about this with their peers, right? So I see many, many more people now in their even 40s and 50s coming in and say, my friend had this problem with urination and you did his procedure and he says it's great and I wanted to come talk to you about it. Maybe not quite as much with Peyronie's yet because it's a little bit more sensitive thing to talk to, but ED in general, BPH, fertility problems. I'm seeing a lot more people come in saying, hey, a friend referred me, which means they must be talking to their friends about it.
Yeah, it's great. I was hoping you would discuss a little bit about the natural history of the disease and the natural progression of the untreated patient who develops new onset Peyronie's and how it may actually go in its course.
Yeah, so that's why I was saying it was kind of unfortunate to hear the misunderstanding throughout history about how it was caused. Because now that we have a better idea about the causes of it, I think it makes a lot more sense to people that it's not anything they did wrong. It's maybe a genetic predisposition combined with some type of injury. And the best way I can state it for my patients when I'm talking to them about it, I'll ask them a quick question, like, was there any specific event with sexual activity or any specific sporting event or cycling event where you fell on the bar of your bike, where you remember some trauma that was painful, uncomfortable, the penis maybe led to bruising or swelling? And then did this change start afterwards? Did you feel a bump? Did you see a curve? Did that start within a few weeks or a month after some event? Over 80% of my patients, there's no event they can remember that started it. In those patients, we have more of this micro trauma thing, right? So you're talking about your men's health run, and this kind of analogy speaks a lot to runners and people who train a lot. There's this thing called shin splints. When you run miles and miles and miles of training, you get this micro trauma in your shins, and it can be quite painful. And it's not a full fracture or a break, and it wasn't any one step or any 1 mile you ran. It was thousands of steps or hundreds of miles, and that repetitive trauma of your feet on the pavement causes an injury. Well, 30 plus years of having sex in men, there's forces and vectors with physics. It gets complicated, but we ask a lot of a penis for penetration with a partner. And in doing so, we put a lot of stress on it. And those micro stresses over time, in some people, they just seem to be more prone to this inflammatory reaction, lays down this scar tissue called collagen. That collagen becomes less elastic. Then that plaque, we call it, that forms as a result of that injury, whether it be acute or long term, then causes a loss of elasticity, a loss of stretching in the penis in that area. And then that area not stretching effectively while the rest of the penis does is what causes it to curve in one direction or another. It curves in the direction of the deposit of the scar tissue from the injury. So when we talk to our patients about it in the office about what it is, how it's formed, and that they did nothing wrong, I think it helps them understand the process and makes them more ready to talk about treatment options.
Have you had any cases where it just spontaneously resolves?
So if you look at the natural course of this, it kind of gets interesting to talk about the chemistry, and we'll get much into that. But this collagen that's deposited has a triple helical structure. So a lot of people know the structure of DNA is these two helixes kind of wound together. When you wind things together, it gives them more strength. So collagen is a triple helix. It's three fibers wound together, and the bonds that bind it are hidden in the middle of that weave. And so it's a very stable complex once it's created. So the natural course of this disease is that maybe about 40% of people in the first year stabilize, about 40% get worse, 45%, and maybe 10 to 15% of people will improve. So if from the time you noticed something, you just wait, most people stay the same or get worse. A small percentage of people will that curvature improve. Now, there's a subset of patients where they're having pain with their erections, pain with sex. The pain often improves over that 10, 12, 14-month range, but the curvature in most people does not. It either stabilizes or progresses.
What kind of treatment do you use in those early stages when they have particularly the inflammatory process causing the pain and discomfort?
So a lot of patients traditionally would come in a year, 2 years after this happened, right? So we sometimes in the past weren't seeing patients early on. I am seeing a lot more patients earlier now, like we said, from this direct-to-consumer marketing, people talking to each other, or men just being more in touch with their health, like, hey, this bend didn't used to be there. Something's changed. I should go see my doctor. Whereas before, guys might have had the tough it out attitude, and I'm just going to see what happens. So I am seeing more and more patients early on. So Peyronie's disease is kind of broken into acute and chronic phases, upfront and longer term. The first 6 to 12 months, depending on who you talk to, would be that acute phase. And the acute phase is a hard process to deal with because some of the treatment options we have later on aren't approved in the acute phase. We're working on some studies there maybe to get it approved in the acute phase or make it at least more of a reasonable option. But for the first 6 months, like if someone comes to see me 2 months after their curve started, we're more concentrating on things that might stabilize it. So there's not great evidence on other things that stabilize it, but if they have erectile dysfunction, maybe like a daily tadalafil medication, the generic for Cialis to promote blood flow, something called pentoxifylline or Trentol, which helps promote blood flow and healing in other injuries in the body. Active stretching devices. So there's different stretching devices people can use to try to reestablish their elasticity. So a few medications to choose from, maybe some stretching devices and what we call traction to try to minimize the change, stabilize it. But in the first 6 months, we are a little bit limited in our options. Once we get into the longer term phase, we've got some other options we could talk about.
Back in my early days of treatment and training, we used to use a combination of vitamin E and Potaba, and never really felt it did a whole lot. Vitamin E seemed to make men feel a little bit better because of its antioxidant effect, and so there may have been just a general benefit, but then there's been some toxicity reports on vitamin E, and they've been recommending to avoid cardiotoxicity to drop your consumption from 400 units a day to 200 units a day. Have you ever used colchicine out of curiosity?
I'm not currently using it. I have seen some papers on it. I think it has about equal evidence to a lot of things, which is not terrific evidence, unfortunately. I am hoping someday in the future we'll have something in that acute phase to really try to cut off that inflammation at the pass, because everything else we have is to try to deal with it after the fact. So I think that will be a big advance someday if we get something that will kind of halt or improve that inflammatory process in the early phase.
So just out of curiosity, are you aware of any famous people with the disease that have actually been in the news?
Not in the news. I know one or two people that um, have kind of talked to their physicians and things about it and have said they could share their story, but maybe not publicly. But I think if people heard the names of some of these people that I've heard of, with their permission, of course, you'd be surprised. And like we said, we think it's up to 10% of the population. So, I mean, just think of, 100 stars, and probably somewhere around 7, 8 to 10 of the men would have Peyronie's disease of some sort, and there was one famous president who was on record that some women identified him in court by the angle, the shape, and the appearance of his genitalia. And that was most likely Peyronie's disease.
So
It
that
was
was my
not.
bait. That was my bait. I was hoping you were going to go there because Bill Clinton was the one person where he had more than one person who said, yep, he's got this unique curvature and he can never have sexual intercourse. It only can be oral sex. And I always thought, well, I didn't get that. At that time, I was still young in my career. I didn't understand it as well. But now I have a much better understanding and go, yep, that's probably it.
So hopefully he sought out treatment after that.
Hopefully, and treatments have gotten better. In some cases, do you think the treatment could be worse than the disease?
So it depends on the degree of your problem, right? So there are some patients who come to see me where a large degree of it's anxiety and maybe body dysmorphic disorders about the change in their appearance, right? And they just have a hard time coming to terms with my penis looks different. But I'm very careful about the treatments I offer when it's functionally doing well. If it's not causing pain, if you can have penetration, if you're enjoying sex, it's just about how it affects your perception of your manlyhood and erections, then I would be very careful about treatments in those patients because you could have some side effects or disadvantages. But in the more severe curvatures where it causes pain for their female partner on penetration, causes the man pain on penetration, or is just basically causing the penis to fold on penetration, if they're not having sex now because of the curvature and they had some kind of issue or complication, well, then it's not a net loss, and we've tried a treatment, right? Because some of the treatments can have some associated risks, discomfort, time investment, financial investment, whether that be from your insurance company or from you yourself. So it's not as easy as here, take this pill that has no side effects, unfortunately.
Yeah, functionality is everything. You talked before a little bit about the use of the PDE5 inhibitors, either Viagra or Cialis, and also the use of a vacuum erection device for stretching, for kind of stretching exercises. Is there a role for penile injection therapy for men with Peyronie's disease and maybe some mild or moderate erectile dysfunction?
So when you're talking about injectable therapy, we'll break it down into the therapy for erectile dysfunction, the vasoactive substances, right? So if someone is having difficulty getting an erection full enough for penetration, sometimes it's hard to judge, is it the quality of their erection firmness or is the curvature preventing sex? So in those people, we'll do our best to optimize their erection function as far as the firmness to kind of judge how much the curvature is bothering them. So there are medications like Trimix and Edex and Caverject, which are injectable agents you can do just to get a better erection. And those are things men can do at home, and we can teach them how to do it in the office. Then there's injectable medications that you can inject into the scar tissue or the plaque, for example, which would be a direct treatment for the Peyronie's disease and the curvature itself. So Xiaflex, for example, is a brand name product. It's the only FDA-approved medication for injectable treatment of Peyronie's disease for the curvature. And that's a treatment I offer a lot to men, and it's been around, almost 12 years now at this point. And it has a lot of data behind it, a lot of safety literature. There are some issues to discuss with our patients if they're choosing to do it, but it's a proven injectable material for this that is FDA approved.
So when is Xiaflex indicated as a potential treatment for somebody who presents with Peyronie's disease?
So currently, we don't typically use it during that acute phase we talked about. We like the plaque to stabilize, and part of that is just to kind of be able to judge improvements or changes. If you're in the active phase where your curve is getting worse and we do a treatment and it stops getting worse, is that actually an improvement? Maybe, but it's hard to judge. So traditionally, it's been used in the more stable phase once there's not a change in the curvature. But we inject it directly into that scar tissue to loosen it over time. It's a series of injections that we can provide for patients.
You think there's any other injectables that have efficacy or a role in treatment?
So in urology, we have what we call the AUA guidelines, and there's AUA guidelines for Peyronie's disease now. There weren't for a long time, but we've had them for a few years. There's a couple other injectable agents that are listed on that set of guidelines. Interferon is one, but the evidence level for support of that was rated lower than Xiaflex. And the other one, verapamil, we had used for a long time, really has very poor literature in support of it. I basically haven't used verapamil at all since Xiaflex was FDA approved, unless someone's insurance forced them to try it before they would pay for the Xiaflex. And last I'd heard, interferon wasn't available in the US currently. So when you're looking at what we call our AUI guidelines, the best literature and the only FDA-approved medication is Xiaflex.
And what kind of statistics do you quote for most men as far as how much improvement that they're likely going to achieve based upon their degree of curvature at presentation?
So if you look at the original data from the company that had Xiaflex approved, it was Auxilium Pharmaceuticals at the time, now Endo Pharmaceuticals. They had two fantastically created trials where they tracked just not the change in curvature, because while we focus on the curvature, another important point is change in what we call their bother score. So there's a questionnaire you can give patients to rate how much the curvature is bothering them. And some guys with a lower degree of curvature may have a higher bother score. Some guys with a higher curve may have a lower bother score. So I think it's equally important to assess their change in perception, penetration, all those other factors along with the curvature. So these IMPRESS trials that have over 1,000 men in them that got the FDA approval for the medication followed both of those things. And so what they quoted after the end of those two trials was about a 35% improvement in curvature. But I think it's important to remember this was like the first 800 or 1,000 men that had treatment. All of the people doing the treatments were new. I've now been doing it for 12 or 13 years. I've injected thousands of people. And I think my techniques have changed. My way of doing it has evolved. I feel like my success rates have improved. So if I'm quoting someone my personal results, what I see in my practice, not what they quote from the company, I say about 50%. So my patients, I'm hoping for about a 50% improvement in their degree of curve. I would consider that a good response. So we'll see a little less in some people, a little more in others. But that's the literature and the information and my personal experience I quote to my patients.
So far, this is pretty much considered kind of a conservative approach. There's a surgical approach as well. When do you think surgery is indicated, and what kind of surgical procedures are options for patients?
So for surgical correction, once again, we try not to operate during an acute phase, because if you tried to correct a curvature while it was still evolving, you may get it straight for a time, but then if the process was getting worse already, it will continue to curve after your surgery. So once again, that acute phase, we call it, of the first 6 to 12 months, we're a little leery of surgery during that phase. And during that acute phase, like I said, we'll just back off of that. But surgery is a great option for people with very severe curvatures. So Xiaflex is mostly for people with between a 30 and 90 degree curvature. And part of that is just expectations, right? So if I tell you we could get up to a 50% improvement on average for my patients, and you had a 90 degree curvature in your penis in like the upward direction, almost the right turn, then if we get a 50% improvement, it's still going to be about 45 degrees, right? And is that an improvement someone's going to be happy with? Somewhere around 40, 45 degrees or less, most men can then achieve penetration. Even if it doesn't look and feel the same, they could have a penetration. So for some guys with a 90 degree curve, that answer might be, yes, let's try it. For some people with a 90 degree curve, they may say, that's not going to be a good enough response. Let's talk about surgical options. Or for somebody with an over 90 degree bend or a really densely calcified plaque who might not respond as well to the Xiaflex surgery, might be a primary option. And of course, sometimes we still run into an issue where somebody wants Xiaflex, their insurance won't cover it. Financially, it's not something they could do because the medication can be a little pricey if you have to go out of pocket for sure. Then sometimes I've done surgery for patients who just can't get Xiaflex coverage with their insurance company. Two main surgical options, depending on the degree of their curvature and their status of their erections. There's something we call a placation surgery. The way I talk to my patients about this is if the Peyronie's plaque is a scar that's causing your penis to bend up, for example, then that scar is on the top. I can make an equal and opposite scar on the bottom to bring it down. So you balance the scar on one side with basically an artificial scar on the other, very successful in straightening the penis, but has some downsides because scarring shortens the penis. So if you have a scar on the top, it'll make a scar on the bottom. Short plus short equals short. So guys can lose some length in that procedure, and depending on how much curve you have to fix, the more curve you have to fix, the more length they can lose. So I'm using the plication surgery usually in guys with 60 to 70-degree curve or less. Otherwise, the loss in length is usually not acceptable. So you get into that 70, 90 or more degree curve, then sometimes we have to do what we call a plaque incision or excision and grafting. You actually cut the scar tissue out or cut an opening in the scar tissue to relax it and put a patch or a graft over it. That surgery is also very successful in straightening the penis, but can come with a high degree of erectile dysfunction, making the penis straighter but softer. So if someone can't penetrate for activity because of their curve before, and then they can't penetrate for sexual activity because of softness after, they're not going to be satisfied with that result. So that is reserved for more severe cases on average.
And what's the role of implanting a penile prosthesis in an individual with Peyronie's disease?
I think the overall goal of every man coming to see me with Peyronie's disease is to be able to have intercourse again. And so if someone is not having good erections, Viagra, Cialis isn't helping them, those PD5 medications we call it, and let's say they needed an injectable agent just to get an erection, and we were going to have to do Xiaflex injections, for example, for their curvature. If you have both moderate to severe ED and Peyronie's disease, then a penile implant surgery may likely be right for those patients. What you do then is put this inflatable implant in. When you do that, you can do a procedure to bend and model the penis, we call it, break up that scar tissue and straighten it. So then at the end of that implant procedure, you'll have a firmer erection that you can inflate on demand, and you'll have a much more cosmetically pleasing and functional penis.
Got it. And in some men, these plaques can calcify because they've been there either for the duration of time or just the reaction of the collagen formation is so extreme. Are there any specific treatments for plaques that calcify?
So there's research out there, just unfortunately, nothing's great right now. We do know that patients we do Xiaflex on that are highly calcified, on average, will have a lower response rate. So it's not an absolute contraindication. It's just if it feels highly calcified or if someone has an ultrasound and you can see calcifications in it, then Xiaflex, I would just kind of underscore that they may not get the typical response, what I would quote in my other patients. There was literature about penile shockwave treatment in other countries, low intensity shockwave treatment to those plaques to see if they could break it up like we break kidney stones. Unfortunately, it doesn't seem to help the curvature much, but it does help pain in patients whose pain hasn't resolved after that 8, 10, 12-month period. So patients with persistent pain have been shown to maybe help with that low intensity shockwave treatment, but it doesn't seem to affect the curvature in those patients.
Are there any role for NSAIDs during the acute phase?
If you see somebody in that very early acute phase, maybe that first 6 weeks after an injury, which I don't usually get to people that closely, I think NSAIDs may be beneficial. Once again, not a lot of literature to publish on that, but it is a injury type response. And so it only seems to make sense. But once again, it's that kind of thing where we just don't usually get to guys quite that early.
And I know you've treated hundreds of men with Peyronie's disease. You have quite a reputation with the folks who make Xiaflex, and you've spoken on this product around the country. So you have a lot of expertise in all of this. Are there any future trends that are coming out in the treatment of Peyronie's disease?
So, it'd be great to see other competitors in the market, options to provide patients. I have not read any great literature about anything on the horizon. When they started studying the low intensity shockwave treatment for it, a lot of us were excited maybe that would help, and the literature just didn't seem to pan out. So right now, in reviewing journals and going to meetings, I don't think there's anything in the next 3 to 5 year time frame that's going to be great new options for us. Back when Xiaflex did come out, I saw some of the earlier patients who were treated, and that was a 3 to 5 year process, seeing the first people injected to getting it approved to being able to offer it to my patients. So kind of realistically, with the way that process works in medicine, it's going to be a while before we have new options.
Yeah. Just out of curiosity, anything new for erectile dysfunction in the future?
So that same device we were just talking about, the low intensity shockwave treatment, it is approved or cleared by like the European version of the FDA. The machines are FDA approved in the US for other treatments in humans. So it's not that the machines aren't available or aren't safe for humans. I think the literature from Europe looks very good about this low intensity shockwave treatment treating erectile dysfunction and helping people improve. It's not going to be a cure all be all, but I'll tell patients when it's available locally here, it may take them one step back. Like if they need Viagra, maybe they don't need it anymore. If Viagra used to work and it stopped, maybe it will start working again. But those low intensity shock waves seem to promote ingrowth of new blood vessels, angiogenesis, we call it, and that may help turn back the time, so to speak, somewhat. A lot of research out there that has a long way to go about stem cells and these P shots. And I just caution people who are reading about that online, be very careful about where they go and where they do that, because they're going to see people charging $3, $4, $5, $6,000 for these very experimental treatments with either not better than placebo or fake treatment rates. You know, a placebo is a fake treatment, basically. And when you compare some of these expensive treatments, they don't seem to stand up much better than pretending a treatment, right? So I'm a little careful about offering those treatments yet. I think they've got a ways to go.
And that's kind of one of the things that makes me anxious about a number of what we would call shot boxes, or these clinics that are popping up on the street, which are designed to help men improve men's health. But sometimes they're more in the business of just selling you whatever they can sell you to make you feel better.
So sometimes when I give lectures on men's health, I'll kind of talk to other urologists about missed opportunities. I feel badly when we lose patients to these clinics because it's because of advertising and shock effect. But if a patient's been talking to you about their process and they trust you as a physician and they see something advertised, they'll probably talk to you about it before they go spend $3,000 on it. If they don't feel like your doctors listen to them, if they don't feel like you're paying attention to what's bothering them sexually, if they don't feel in tune with you in that way, then they might just go say, well, I'm going to go try it and spend my money on it. Where if they came to talk to you about it because they trust you and feel like you're in tune with their needs, then I feel like we have an opportunity to keep those patients. So, you know, it's hard sometimes in the world of medicine to pay attention to every detail. But if we're not asking them questions about their sexual function because we're focused on their prostate or something else, then we lose those patients, right? So every patient in my office over the age of 40 who comes in for kidney stones, BPH, they get 2 screening questionnaires, a symptom score for prostate and a symptom score for erectile dysfunction. And on the end of the erectile dysfunction score, I added an extra question about, do you have a lump, bump, or curve affecting your erection? So any guy walking into my office gets screened for BPH, erectile dysfunction, Peyronie's disease, because you might be there about your kidney stone, but you might have Peyronie's disease. And if I don't ask them, they won't talk to me about it. They might end up on the internet and pay $6,000 for some treatment that maybe won't be beneficial.
And that's what makes you a men's health advocate, because a lot of urologists would just stay hyper focused upon the issue at hand and would not actually delve into the other issues that actually affect their entire persona. And I think that that's really a missed opportunity as a urologist, is to not be that advocate for all aspects of men's health. So I guess I'm kind of curious about your personal thoughts on the importance of male sexual health as far as the overall well-being of men.
So, you know, while men don't talk about it very much with each other, I think if a man went to a therapist, it might be a big part of what they talk about sometimes. So when we look at Peyronie's literature, it's hard to show the exact causation, but probably somewhere in the neighborhood of 50 to 65% of men with Peyronie's disease suffer from depression. And when you think about it from the standpoint of a male, you're like, well, let's say you were married for 25 or 30 years. Intimacy is a big part of your relationship. You develop a severe curvature where you can no longer have that intimacy with your partner. You lose that part of your relationship. That's going to cause depression in a lot of men because it has changed their relationship. And I've seen people come to see me worried about losing their partner, right? How can that not be a source of depression? So it's a big deal for a lot of people.
Yeah, yeah. So you've been a real advocate for men's health. What do you think is the missing piece to really advocate and help improve the health of men overall?
You know, I've been advocating for a much more streamlined way to do it. So my ultimate vision at my center is to create a one-stop shop. So I'd like men to be able to come to one place to see any doctor they needed. See the urologist, see the cardiologist, see the internist, see the endocrine doctor, get that GLP-1 medication for their weight loss if they're severely obese, get their blood pressure medication so they don't have a stroke. You know, all those kinds of things that men need. Get your screening colonoscopies, get your blood work. It's something I've been working for a long time, and hopefully I'm getting a little bit closer. But I think that interconnection between the specialties has sometimes been missed, where there's an overlap between diabetic patients and patients with erectile dysfunction and Peyronie's disease. There's an overlap between Peyronie's disease and depression. Are we referring those people out for counseling to help them deal with this kind of body dysmorphic disorder where something has changed in their body and causes anxiety in them? So I think the intra-referrals and the communication is going to be important. And then like I said, the getting men in the seats, right? If they don't come talk to us about it, we can't help them about it. So I think that is slowly changing, and some of the marketing that educates patients and people talking to each other, and just maybe some changes in societal norms where, for example, now getting it out there that Peyronie's disease is more of an injury and not incest, right? Like, I know that was hundreds of years ago, but having men just understand, hey, this is normal. It happens to a lot of people. There are treatments out there. Then I think they'll come in and talk to you.
Well, I think you really touched on an area that is very near and dear to me, and I've been trying to see for years if I could get that created, which would be a real holistic, as far as whole, WHOLE, men's health clinic. And I've always thought that the best first patient would be that patient who's diagnosed with prostate cancer to come on in and get a psychological evaluation, get a cardiac evaluation, get a nutritional assessment, and try and improve the way they go through their diagnosis, management, and overall survivorship. And I think we had a real missed opportunity to not have engaged men when they're faced with a diagnosis like prostate cancer, which has such a high association with anxiety, depression, and even suicide. So I think it's just so many missed opportunities as urologists, as we've missed that opportunity to be the true male health expert and to be their leader for men's health. And the American Urologic Association has never really stepped up properly to actually make men's health in the forefront of what we do as urologists.
Yeah, the AUA has a men's health checklist now, which is interesting, which is basically by age group, the kinds of things men should start to think about with their health. The more we get that kind of information out there, like it's not just at age 45 you get a colonoscopy. That's not the only thing you need to do. If we get people more in tune with that, keeping up on their health and that body maintenance kind of issue rather than dealing with problems after they've happened, I think that's going to be important. So, but yeah, I think we've disappointed or undertreated a lot of patients we could have helped avoid future problems or help them deal with the psychological ramifications of cancer and sexual dysfunction.
Now, I know for a fact that erectile dysfunction, Peyronie disease is not exactly the form thrust of your fellowship that you did at Baylor. So tell people a little bit about what you really did specialize in Baylor as far as the role of fertility and fertility outcomes.
So part of my fellowship was in sexual dysfunction, but the other part was in more what we call andrology and microsurgery. So I do a lot of work with infertility patients on the male side of things. I don't do the female side of things, but for patients struggling with fertility issues, we evaluate them for different causes of male infertility, order the semen test, the blood work, the evaluation. For people who've had a change in their life status and maybe had a vasectomy and now desire future children, vasectomy reversal procedures. So that's a big part of my practice too, is helping with fertility patients. So, I mean, I know it's all kind of in that realm of relationships and sexual activity. And, it was tough in residency, medical school and everything. And I just kind of realized as a doctor, I didn't want to tell patients they had cancer all the time. And I didn't want to tell them their cancer surgery didn't go well or their life expectancy was 5 years. I wanted to help them be sexually active. I wanted to help them have children. Some of those positive things that I could do. So as a urologist, I just kind of came to terms with what I would enjoy doing. Somebody has got to do all aspects of urology, and this is what felt right to me.
Yeah, no question about it. And I'm just a curious question. Do you have any thoughts as to why sperm counts have been decreasing significantly globally since the 1970s?
Yeah, and it's interesting. A little over 10 years ago, the WHO changed the normal ranges for semen test, with the only reason being that over the last 100 years, it has trended down. And so it's interesting that just because it's trended down, they changed the normals, right? So all of a sudden, we've just reset our baseline to fit the current population. So, I mean, you look at all this literature over the last 60 years about environmental changes, whether that be greenhouse gases, all that kind of stuff, and you see environmental things changing along with sperm counts dropping and the general health of the population, obesity rates being much higher. So I mean, I think it's trending in the wrong direction with life expectancy too, right? It might be the first generation or so that's life expectancy isn't longer than their parents. And so I think that's that focus on men's health too, about what we do when we're young to stay healthy, continue being healthy, right? And so I think we have a lot of underutilized tools out there to help men do that. So a lot of times we're looking at fertility in men. There's antioxidant vitamins they can do, weight loss medications to support their testosterone production, a lot of things we can do to help them.
Well, you've done a lot in your short career so far, and I'm not sure how many years you've been in practice, but you still have a long time to go. And I'm just kind of curious, what do you envision would be your legacy, the trail that you want to leave behind you, and the impact that you've had on the men that you've treated?
My legacy is in the patients I've treated and also in the residents we've trained, right? So when I was at Beaumont and Corwell, we were working with residents. When I moved to another hospital, we were working with the DMC residents. Now that I'm the University of Michigan Health Sparrow, I'm training residents there. And so I love working with residents and the new trainees coming through to kind of make sure they know how important this is, right? Because I don't know if I got the emphasis on that till I got to my fellowship because I expressed my own interest in pursuing that field. But I think in a lot of urology training programs, the infertility, andrology, ED kind of stuff is maybe less of a focus than cancer. And so I like bringing that to our residents in our program, and I think they enjoy that part of their training.
Well, you're definitely leaving an impact in such a positive way for men's health, for your patients, and as well as being just a great guy. And I really appreciate our friendship. I just want to
Thank
thank Dr. Richard Bennett for being with us tonight, for sharing his thoughts, his knowledge all about erectile dysfunction, Peyronie's disease. Our Michigan Men's Health Foundation is growing, is expanding around Michigan. We hope that you'll keep track of all of our outreach activities. This year, June is International Men's Health Month, as it has been in years past, and we are partnering with the state of Michigan and through the governor's office to celebrate men's health advocacy during International Men's Health Month, to make it a campaign throughout the state of Michigan. Please remember we have our events coming up in June 9th with Blue Monday and Cogs and Kegs, June 12th, Mulligans for Men, June 15th will be our Run for the Ribbon at the Detroit Zoo, and in September, we'll be having our men's health event, and you can always go to our website to see the date of the event after the Lions announce their schedule. I want to thank our partners and sponsors, particularly Corewell Health, American Cancer Society, Blue Cross Blue Shield of Michigan, and Blue Earth. And if you have a topic or something that interests you that you would like us to cover in the future, please reach out to us, and send us an email and let us know what is that topic. And also, if you are available to volunteer or support our foundation, we can always use the help to help the other men of our community, especially as we expand throughout the state of Michigan. And I just want to thank you for joining us tonight and being a part of our first Men's Health Survivorship series. Thank you very much.